Welcome to Vasopressors Explained for ICU nurses. Whether you're a new grad stepping into the unit or a seasoned nurse brushing up, this video is for you. We'll break down the 5 major vasopressors, what they do, how they work, and what you need to watch for at the bedside.
In the ICU, vasopressors are among the most powerful medications you will manage. When a patient's blood pressure drops to dangerous levels, from septic shock, cardiac failure, or anaphylaxis, these drugs step in to keep vital organs perfused. Your role as the nurse is critical. You're the one at the bedside titrating the drip, reading the trends, and catching complications before they become catastrophes.
Vasopressors work by acting on adrenergic and non-adrenergic receptors in the cardiovascular system. Alpha-1 receptors squeeze blood vessels, raising SVR. Beta-1 receptors increase heart rate and contractility. Beta-2 receptors dilate airways and peripheral vessels. And the V1 receptor triggers direct vasoconstriction independent of the catecholamine pathway. Each vasopressor agent has a different receptor profile, which is why we choose them differently.
Norepinephrine, brand name Levophed, is your workhorse vasopressor. It's the first-line agent for septic shock according to the Surviving Sepsis Campaign guidelines. Its primary mechanism is potent alpha-1 stimulation, causing vasoconstriction that raises systemic vascular resistance. It also has mild beta-1 effects, providing a modest boost to cardiac contractility without driving the heart rate dangerously high. Dose range is 0.01 to 3 micrograms per kilogram per minute, always through a central line.
When your patient is on Levophed, your monitoring priorities are clear. First, know your MAP goal. Most orders target a mean arterial pressure of 65 or higher. Track urine output hourly. At least 0.5 milliliters per kilogram per hour tells you the kidneys are perfused. The critical safety issue, extravasation. Norepinephrine is a potent vasoconstrictor. If it leaks into tissue, you'll get necrosis. Central line confirmation before starting is non-negotiable. Also, assess skin warmth, cap refill, and overall perfusion.
Epinephrine is the body's own stress hormone, and in the ICU, it's the go-to drug for 2 emergencies, cardiac arrest and anaphylaxis. It stimulates all 3 adrenergic receptors, alpha-1 for vasoconstriction, beta-1 for heart rate and contractility, and beta-2 for bronchodilation, making it uniquely effective in anaphylaxis, where you need all 3 effects simultaneously. In cardiac arrest, it's given as a 1 milligram IV push every 3 to 5 minutes. As a continuous infusion for shock, doses range from 0.01 to 1 microgram per kilogram per minute. Epinephrine is powerful, and your monitoring needs to match that. Tachycardia is almost universal. Heart rates above 120 are common and expected. More concerning are dysrhythmias. Watch the telemetry for PVCs and ventricular tachycardia. One important nuance, epinephrine infusions often cause elevated lactate levels. This does not automatically mean the patient is deteriorating. Epi stimulates glycolysis, producing lactic acid independent of tissue hypoxia. Trending lactate matters more than a single value. Monitor MAP continuously and ask your patient about tremors, anxiety, and headache.
Vasopressin is in a different class from catecholamines. Instead of acting on adrenergic receptors, it directly stimulates V1 receptors in vascular smooth muscle, causing powerful vasoconstriction through a completely separate pathway. This makes it especially valuable as an add-on to norepinephrine in refractory septic shock. Adding vasopressin allows you to reduce or spare the norepinephrine dose, which lowers catecholamine exposure.
One critical difference from other pressors: vasopressin is given at a fixed dose of 0.03 to 0.04 units per minute. You do not titrate it like a catecholamine. On vasopressin, your top safety priority is ischemia. Because V1 receptors are everywhere, intestinal vessels, coronary arteries, digital vessels, vasoconstriction can be dangerously severe. Watch for signs of mesenteric ischemia, like abdominal pain and distension, digital ischemia with cold blue fingers, and EKG changes suggesting cardiac ischemia. Monitor blood pressure closely, assess perfusion frequently. And remember, this drug runs at a fixed dose. Don't be tempted to titrate it up like you would norepinephrine.
Phenylephrine, neosynephrine, is the purest vasopressor in our toolkit. It has absolutely no beta activity. It acts exclusively on alpha-1 receptors, squeezing blood vessels without touching heart rate or contractility. That makes it ideal when you need to raise blood pressure in a patient who's already tachycardic, because phenylephrine will actually slow the heart rate through a reflex mechanism. Anesthesia uses it heavily in the OR for this reason. Dose range is 0.5 to 6 micrograms per kilogram per minute, and it can be given peripherally in urgent situations.
The most important side effect of phenylephrine is bradycardia, that reflex from pure vasoconstriction. Watch your heart rate and report significant drops. Assess distal circulation. Cold, mottled extremities may signal excessive vasoconstriction. The most important contraindication: do not use phenylephrine in cardiogenic shock. Because it has no beta support, it can actually reduce cardiac output and worsen the situation. Monitor MAP every 15 minutes during titration and confirm the reason this drug was chosen. Context matters.
Dopamine is unique because its effects change depending on the dose. At low doses, 2 to 5 micrograms per kilogram per minute, it acts on D1 receptors in the kidneys and gut, causing vasodilation. At mid-range doses of 5 to 10, it shifts to beta-1 stimulation, increasing heart rate and contractility. Above 10 micrograms per kilogram per minute, alpha-1 dominates, producing vasoconstriction. However, modern guidelines have largely moved away from dopamine for septic shock. Compared to norepinephrine, dopamine causes significantly more arrhythmias, particularly atrial fibrillation. With dopamine, your primary concern is arrhythmias. Atrial fibrillation can develop rapidly, especially at higher doses. Keep eyes on the telemetry and be ready to act. Blood pressure monitoring needs to be frequent because effects change as doses shift through the 3 ranges. Precise dose calculation in micrograms per kilogram per minute is essential. Small errors have real hemodynamic consequences. Like norepinephrine, dopamine carries extravasation risk, so a central line is strongly preferred. And remember, current guidelines favor norepinephrine over dopamine for most shock states. 5 practical tips to carry with you every shift. 1. Know your MAP goal. Most orders target 65 millimeters of mercury or higher. Document when you achieve it. 2. Monitor urine output every hour. Oliguria is often your first sign of inadequate perfusion. 3. Assess the whole patient. Vasopressors treat the number, not the patient. Look at skin, cap refill, and mental status too. 4. Never abruptly stop a vasopressor. Always titrate down slowly to avoid rebound hypotension. 5. Verify central line patency before starting and label every vasoactive drip clearly.
Let's lock it in. Norepinephrine, first line for septic shock. Alpha-1 and mild beta-1, your most used vasopressor. Epinephrine, broadest receptor action. Go-to for cardiac arrest and anaphylaxis. Watch for tachycardia and dysrhythmias. Vasopressin, pure V1 mechanism. Fixed dose, non-titratable. Catecholamine sparing add-on.
Phenylephrine, pure alpha-1, raises blood pressure, lowers heart rate. Avoid in cardiogenic shock. Dopamine, dose-dependent, falling out of favor due to arrhythmia risk. Know your dose range.
That's vasopressors in a nutshell. Understanding these medications, their mechanisms, their differences, and what to watch for makes you a safer, more confident ICU nurse. Like this video if it helped, subscribe so you don't miss the next lesson, and share it with your teammates. Critical Care Simplified, making the complex manageable, one concept at a time.